Good morning, everyone. I'm going to start, and I just want to give a caveat that our complexity and challenges in the pediatric settings of school-age children is our best guess. And I just want to start with some terminology that I think is really helpful. In the field of autism, you're going to hear a lot more about identity first versus person first language. For the purposes of this talk, I'm going to do person first because that's what's in the medical literature. But it's very important to remember identity first. So identity first is an autism as a personal characteristic and an individual's identity. And they would refer to themselves as an autistic person or an autistic individual. And that's what we recommend you do with your patients. But in this type of setting, we tend to use person first. So these are my topics. I want to try to get through my time. Autism, as everyone knows, is a biologically based neurodevelopmental disorder characterized by persistent deficits in social communication and interaction and restricted and repetitive patterns of behavior, interests, and activities. The caveat for today's talk is really thinking about those children you might not pick up at earlier. You may not pick up early in childhood because it doesn't really fully manifest until the social demands exceed their capacity. And that's really the group we're trying to talk about today, where you've been following them maybe with some concern, but it doesn't really rise to that level till they're a little older. So I'm not going to belabor this. This is the DSM criteria. Just remember you need all three for Part A, and you need 2 from restricted interests and repetitive behaviors, interests, and activities. And what I'm going to do a little bit later is dive in a little bit more in like how they would present in your office and descriptions you may hear from families or schools. Remember, when you're applying the criteria, you really want to think about intellectual disability and language impairment, and that's the group you tend to pick up on. But that's the group that sometimes in your office, they're doing okay for a while, and you may not notice them. I am going to just talk about level severity because that was one of the questions that came up about could you talk about level severity, and I may not be the best person because I don't assign it, and I'll tell you why. If you look at this, it looks pretty complicated, but how you get there is really subjective. There's no one assessment we've all agreed upon that this is how you determine it. And what I think about is that when it's subjective like this, I could see the same patient, one of my colleagues, and we could assign a different one even within the same week. The level assigned at the time of diagnosis will likely change over time. Changing level actually is something where you might consider that there's a need for further evaluation for comorbidity. And then the other piece is medical issues. And so sometimes a child presenting very differently behaviorally, we need to do our rule out of any medical issues that may be contributing to behaviors. The other thing that we found in Maine and across the country is that the interpretation of level of severity by service providers sometimes would impact their level of supports and services, and sometimes even their access. So like level 1, you wouldn't receive anything. And so early on I was like, I'm not going to do it because I felt like it could be used against families. And it wasn't really helpful. And then the early DSM-6 work group is discussing a change, but likely removing it. So I like this slide. I'm just going to leave it there. It's good for referencing, but it's looking across the spectrum of when you see them. And I'm talking about the later spectrum. 2 areas I like to point out. One is that cognition, the very delayed, the child that has global developmental delays in all streams, or that child you suspect will end up having mild intellectual disability, you're picking them up. They're being followed closely. Something is being monitored at school typically, or it's pretty early determined. Versus the child with the splinter skills in your office or at school, they're a little bit trickier, and it takes the later grades before you're going to find them. And then the other point I like to make about this group is that often they're impaired in some way, regardless of cognition, in the area of adaptive skills. And this can kind of manifest with parents talking about the daily routines being really challenging. So this is the group that I feel like the parents are coming into your office, and maybe they're talking about transitions or showering or teeth brushing, and it doesn't really make sense based on other skills the child also presents with. So I have 2 cases that are composite, just so you know. These are not a specific patient, but are meant to illustrate some common ways they present. And I'm presenting 2 cases that I think probably represent some of the 2 most common ways that we sometimes have children we follow that have another diagnosis, but eventually we may diagnose with autism spectrum disorder. So case one, I'm not going to read it all, but this is a 3-year-old male, and I'm going to assign male because he's going to have ADHD. So in the office, you notice first that the 3-year-old well-checked, not worried, but they're very active and impulsive. Eye contact is varied, but some of this you feel like is just because they're so busy and catching their attention is hard. When you prompt, you get good eye contact, you get some shared enjoyment in the interaction, so you're not thinking autism. And parents are definitely like, this is fine. We have an older child who has ADHD. We're kind of ready. We know how to do this. And we expect he'll have it as well. He gets older. You diagnose him with ADHD. You're not surprised. You put him on the same medication as sibling. But early on, you already have a parent says, yes, it helps him, but we notice it does not help as much as his brother. Between 6 and 9, you notice at visits, he can answer questions. What do you like to do for fun? He talks about video games at length. When you ask about school, he likes lunch and recess. When you ask about friends in 2nd grade, he really can't provide names, and that's definitely a pink flag. 1st grade, he's having some RTI, he is having some behavioral issues, and he ends up in a behavioral classroom for some of his day, but he's mainstream for other activities and specials. He ends up with an IEP eventually. ADHD is confirmed by the school psychologist, who also notes a full-scale IQ of 80. By 4th grade, the parents share concerns about his behavior at home being more of an issue and feels like more than ADHD. They feel like transitions are not getting any better, even though he should be getting better at this age. They worry that friends in the neighborhood that used to play with him don't come around anymore to invite him. They notice that when they do try to arrange a play date, he kind of ends up playing on his own in his room and the child is playing with his toys somewhere else. And then when they do try to have a shared interest, that play does not go well because she notices her son has a hard time kind of doing something cooperatively. 5th grade teachers note he can do well, but they are seeing some social concerns. They notice that, he tends to be a follower. He gets prompted to do things by his peers, sometimes saying an inappropriate word that gets a laugh or says something to a peer that's teasing, but he does it anyways. And then he'll stick with things despite consequences. So he's saying the joke too many times and just can't stop, even though all the other kids are no longer laughing. And then one of the things that they notice is that he can be teased by peers and he's not picking up on it. And then they notice that ADHD symptoms are really well managed. It's actually the only times they see ADHD symptoms are in social situations. And the other kind of most common situation is a girl, around 12 years of age. You might have seen her your whole since birth. You notice that screening and surveillance goes well. She does well at visits. She has some mild anxiety. She's the child that negotiates about the immunizations early on with parents, with you. You notice that, when younger, when you asked about school, she did well talking about social rules. She's the one that says, you say, what makes somebody a good friend? And she'll say, a friend is someone that is nice, nice to you. In 2nd grade, when you ask about friends, she might list everyone in her classroom. That's another pink flag. Concerns for mild anxiety often comes up at visit, but nothing at threshold to treat. But parents do report some accommodation. They say, they spend a lot of time talking through upcoming events and changes in routine because they say if they don't, it doesn't go well. By 4th grade, she doesn't have friends. They said she had them in the past. When you ask or they ask her about it, she doesn't know why she's not included anymore with her friendships. She sits alone at lunch. She talks about being teased by a couple boys at lunch. She's always wearing purple, and they always say something to her about wearing purple. She doesn't have an IEP or a 504. 4th and 5th grade teachers kind of talk about some attentional issues, maybe not working to her potential. But when you do an ADHD eval, she doesn't really meet threshold, although there's quite a few inattentive symptoms noted in the school. You see her at 12 because of anxiety. What they say is that she's often tearful about school. It often comes up when she's overwhelmed about completing assignments, when she feels like she's not done something correctly. When she doesn't understand something, they know she just won't ask for help. She's reporting some somatic symptoms, especially on Sunday nights before going back to school. She's often worried and asking many questions about upcoming activities or changes in her routine. And in the past, they could kind of go through it and be fine. Now she has to. She has to hear it several times before she can move on. If parents try to reassure once and move on, or can't give a specific answer. They say maybe or we'll see. That will either be a response from her for tears or she'll explode, which is new. When you talk to the patient, she reports feeling distracted in the classroom, that she worries and she thinks about peers not listening to the teacher, and she's very cognizant when peers are breaking rules. She recounts several issues, feeling upset with teachers because they're not clear about assignments. So she's not just upset about her peers, she's talking about a teacher not being clear. When asked about time with her peers, she says she feels lonely and she wants friends. So I'm going to just pause here and talk about how this might present in your office. I won't read all of these, but I think it's nice to have examples that really represent the school-age child. These are the ones that I go, you have to probe maybe a little bit longer or have a little bit more time talking with them to really see what the issues are. So we think about that diminished or absent social interest or motivation. And so there are the group that are sitting alone. They're standing off to the side. They're always on the fringe. And they're doing their own thing. There's a part of that group that is fine with that. And then there's kind of the part of the group that are feeling lonely and not successful. They lack social know-how in multiple ways. So in your office, I always think about having those conversations, much like a lecture today, monologuing and one-sided. And it could be anybody, and it's like you're not there. It really is, you're like a receptacle, and they're not noticing whether you're nodding your head or commenting back. There's other kids that come in and they're using this ability to talk as a social strategy, because if they're interviewing you, they're in control of the questions and what's going to happen, and it's much more predictable. The lecture style, the kids that'll teach you, that little professor, those are the kids you get them on a topic and you're like, let me take notes. There'll be a quiz later. Tangential speech, this is my favorite one. These are the kids you start down one path and they veer this way and I go, oh, ADHD. However, these are the kids that bring you back to a preferred interest or topic and you're like, how did we get back on Minecraft or Roblox? They're very good at it. They indicate interest, but with abnormal social overture. So they feel like you can't hear them, see them, or listen if they're not right here. They're the ones that say something nice about they like your sweater, but somehow they're over there stroking your sweater and they're 9. Like that would not be a typical way to engage. Their verbal skills may be at their age, but they don't really initiate like you would expect, except to get a need met, or when you try to get them to elaborate and you feel like they could give you details and they don't. And then that back and forth conversation piece, 2 things I notice a lot is they don't clarify if you don't understand. They just kind of keep going in the conversation, even if you kind of show you're not understanding non-verbally or verbally, and they don't provide background. It's like you're suddenly in the situation with them. And a 12-year-old should be able to understand you might need some context. Cognizant of time here. So the second one I think is interesting, that it's not eye contact all or nothing. These are the kids, it's the nuanced eye contact. If it's absence under 2, yes, very indicative of ASD. These are the kids, though, that they're talking to you and they're looking so intently and you're kind of like, you're not blinking, you're not turning your head, there's not a lot of movements. And the other one that I notice is that they're talking to you, but their body is turned a little to the side, right? There's something else like away always in the conversation. Atypical language, you might hear echolalia, but they're using it in a really good way. They're reframing it. So you might say, lots of kids tell me they don't like eating in the cafeteria. It's really loud. How, what do you think? Or how's it go for you? And they'll say, yeah, the cafeteria is really loud. I don't like eating there. They just switch it around and that's how they give you a response. They may use some really nice social scripts functionally, and that's where they might ask, how are you? What do you like to do? Do you have a dog? They'll do a couple turn taking using those phrases. Prosody, volume rate, I always talk about sometimes you're in a conversation and sometimes you think you're talking to somebody that's in character. And it kind of catches you and it sounds familiar and you realize it's not quite their voice. And my other thing that has happened over the years is sometimes, I'm not sure why, but it's like suddenly they have a British accent. I'm not sure how that happened, but it's just in the conversation and they're not recognizing that's what they're doing. Abnormalities in understanding and using affect, it can be really limited. So this is kids with really restricted or flat affects, and they've kind of always been that way since a young age. It takes a lot to get a smile, or exaggerated use. These are the kids that can sometimes feel really dramatic and everything's big almost to get their point across. And then these older ages, they cannot use words to describe emotions, even though they can understand it when you say it. They're not using that language. And then just being able to recognize or interpret others' nonverbal expression. Sometimes you might test it in the room, or you're typing and you're doing this and they're not recognizing that you stopped listening, or they're not picking up anything over. The other thing that I think is really important is it's really about relationships. In the school-age child, it's much harder to get that information. Parents don't always know. Relationships change a lot from elementary to middle school. And so sometimes getting the detail about why there's issues with friends or what's going on with them, it's hard to dig into that. Some of the things that I recognize as being when I hear it, I'm like, oh, okay, maybe that's the issue. It's limited to no interest in peers. There are children that will be, I like to sit alone. I don't want to do group projects. And there's the kids, if you get them to expound on what's going on, especially in late elementary, they'll talk a lot about how their peers are annoying, and they'll go on at length. They might want friends and then feel unsuccessful, lonely, much like our case, but they don't kind of know where things go wrong. They can't really, put their detective cap on and really work through it with you. When they're younger, it's that shared imaginative play back and forth, but it can be on their terms, or it may be rote. These are kids at the later ages might play video games, but they really struggle with playing the online games with even friends from school they know well. They sometimes really struggle across the school age they have one interest and they have it and they share it with a friend and it goes well, and then that friend outgrows them because they get other interests, right? They move on to something that's, grade and age appropriate, and these kids sometimes stay stuck in that one interest. So Legos are very appropriate when they're young, but if that's what you're doing when you're 13, 14, you're gonna find fewer people that engage in that with you. They misinterpret interactions from teasing. They don't know they're teasing. They're being teased and may or may not be aware, or they report a lot of teasing and bullying, but it may actually not be teasing. They're vulnerable to teasing and manipulation, much like the case that I shared. That happens a lot. Engaging with peers that are much younger or gravitating to older peers or siblings and adults. And one of the things that I talk about is that's not a peer relationship. That's not their peer. If they're delayed and they're demonstrating that skills, then that would be appropriate. But the older child that's kind of playing with younger peers so they can control play is a different story. And then families sometimes think, oh, but they're just so mature than their peers, and that's why they play with older kids, or they play with their siblings or cousins, or they're good with me. But we are compensating, and we don't realize we're compensating for their skill delays. And then one of the things that I say is in your examples, you'll find there's highlights of rigid thinking and delayed perspective taking. So if you really get a story from a child, you will figure out that some of the issues are rigidity and perspective taking delays. So I'm not going to do much about stereotyped repetitive speech or motor objects, but I'm giving you some other examples, because things like repetitive hand movements, I talk with my hands, but kids that have history of finger flicking or tapping or twisting their hands or flapping, they convert it into something else. Like they're using the fidgets, they'll sit on their hands. You'll notice that they've kind of found a way not to draw attention. For children for part B, one of the big caveats I talk about is when they're younger and you're hearing about those rituals and routines and that getting stuck piece, and you're thinking OCD, the younger they are, the more you should be thinking about autism in that differential. And then these are the children that sometimes are a little flexible with their parents, or their parents have accommodated them so much that the rituals and routines don't really show up. And then the other part 3 is really that abnormal intensity or focus of interest. And these are the ones that they loved letters and numbers when they were younger, and it was a strength. And now one of their favorite activities is to redraw fonts. So it can change over time, but it's that thread is there. And then preoccupation. So color, timetables, historical events, all things related to sharks, cats, and penguins. They can be a one-time interest, but if that's a consuming interest, that's unusual. And then part 4, I like to just kind of remind everybody that sensory things were not part of the, not in the DSM-4, but they are really important. And for the children that we're talking about here, where cognitive and communication skills are average, they are, they're interesting in that they are the ones maybe walking to school in shorts in December, and parents are like, I gave up that battle a long time ago, but you don't go back to ask that anymore, but then you're like, they're really insensitive to cold. And then the sensitivities that are texture or touch, it's aversion or attraction. And so that's the child that's really still struggling with bathing, and the parents helping a lot, and that does not make sense from their overall motor skills or adaptive skills. But you just recognize it's the barrier, it's the sensory issues that are causing issues. And then these are the kids still are exploring sensory touching. So these are the kids that still have like the blankets and the certain clothes and things that they have to have. So the last thing I'm going to spend some time on is just thinking about comorbidity. So they're presenting more like our cases, ADHD and anxiety in your office. And why is it? Because those are the comorbidities in autism. And so this is a 2020 psychiatric review paper that looked at systematic reviews and meta-analysis. And I really liked it because it looked at a lot of the countries and papers that are similar to how we diagnose autism. So I feel like it gave us a good range from those studies. But you can see ADHD and anxiety is the top. What I found compelling about this, especially as you move towards adolescent and young adulthood, the ones that they're starting to track a little bit more is suicidal ideation and attempts. And that's obviously very concerning to all of us seeing that. And that there's in some studies, it's quite high, up to 66% for ideation. And we're not necessarily asking that as much in this population. And then what I did like about the studies are things that I felt used to be very high comorbidities diagnosed often and at young ages, like bipolar. We're not seeing that as much. I think there's been some decrease in that, and I think these papers have reflected that. And then, kind of the eating disorders, personality disorders, and substance use disorders are things just to consider for this group. And I'll leave on these last two slides. You're in such a great position when you follow families, and so I like these next two slides on comorbidities of the SPARK study. So you enrolled in like 12 centers across the country. They took saliva for genetic testing, but they asked a lot of information about the family. And this is comparing the blue are your patients with autism or the children with autism in the family, and the gray is the sibling that doesn't have ASD. And you can just look, the greater lines are, ADHD, anxiety, sleep disorders. And it looks at like some of them that are quite high because this phenotype in these families, right? Like you see that, you know the parents really well, and the mom has anxiety, and one of the other children has ADHD, and you just start to see these patterns in these families. And then the other thing about comorbidity, autism always, we didn't use a lot of comorbidity in the past, but autism doesn't ride alone. Like that's the thing. And so you can see that even in these families, the siblings actually have one other diagnosis. It's quite high other than autism. And then as you go up, you have a high percentage still having 2, 3, and then greater than 5. And in referral clinics, we would say we have quite a high rate. And comorbidity in autism, most studies will still say 70% have at least one co-occurring disorder. And I think people are less hesitant of giving another diagnosis with autism now. 40% may have 2 or more. In our clinic, I would say our most common diagnoses are autism, anxiety, and ADHD. And then we have, ADHD and anxiety disorders, as I said, are most common. The DSM-5 allows for co-occurring diagnosis. So people who've been doing the DSM for a long time remember when you couldn't. I would do it anyways, but like that took a long time for us to get that understood. And then just thinking about intellectual disability is kind of an exclusion diagnosis at some level because you're always applying the criteria based on developmental level, but we still see that co-occurring at quite high rates. And then the big thing moving into the next talk, which will be more detailed about this, is that diagnostic clarity can come after treatment of other disorders like ADHD and anxiety, and that's not uncommon. And I would say there were plenty of times that I would see a child and try to do an assessment, and I had to treat ADHD in order to actually even feel like I could do a good assessment and get good data myself and from parents and school. So here's my pause. And I'm going to move it over to Dr. Nielsen.
Just let me know, give me a thumbs up if I need to talk louder. So I'm Matthew Nielsen. I'm an outpatient child and adolescent psychiatrist, and I'll just introduce the context in which I work, because I think the context of someone's work is so important. I think in terms of understanding how they think about things. So I want to kind of give you that information about myself. So I work 4 days at Maine Medical Center in our outpatient clinic, and then I work one day at the Glickman Center, and so I'm pretty early career. I did a lot before starting medical school, but so I've been in practice as an attending child psychiatrist for a little under 4 years, and I would say that sort of like thinking about patients on the, for lack of a better term, high functioning end of the autism spectrum disorder has been a very large part of sort of my role as an outpatient child and adolescent psychiatrist. Like I think I was surprised about sort of how much of the patients I see that would be a very relevant question. And I would say that that's actually been sort of the biggest area of learning for me as an early career child and adolescent psychiatrist. I would also say, like, I can look back to sort of when I was like earlier in training and I was like an adult resident. I sort of cringe when I think about cases where I worked on. I thought, oh, this isn't autism, you know. And I think I've probably gained some more humility over time. And I would say, if anything, I've sort of I probably would diagnose more of the, or think about that question more frequently as time's gone on. So I kind of tailored my talk mostly to sort of like the frame in which I am sort of interacting with patients. And so usually that's, ranging from like age 4 to 17. And I want to say just a little bit about kind of like what the sort of process in which we get referrals, and sort of, because I think it really, so sometimes we'll get referrals and there'll be like in the referral there'll be a question about autism spectrum disorder, and sometimes there won't be. And what I would say about that is one thing I've also over time, I've been a little bit more cautious about how I introduce the construct of autism spectrum disorder. And that's probably because I was maybe too eager in the beginning. So like I try and read the room first. There have been a couple of times where I haven't read the room and realized that, okay, like I was so eager, maybe it was like my own intellectual vanity, to sort of put this idea out on the table. And I've had a couple of times where that really, it didn't go so well. So I think that's really important, to sort of like take the temperature of the room and take your time. Like it's always, so I definitely made that mistake on a number of occasions, and that's something that I've learned over time, is to just like slow it down. So like I will ask questions about, if I'm thinking about this, I'll say to like a parent, are you thinking about anything else? Do you have any other like things that you're wondering about? And if they don't bring it up, I don't bring it up in that first visit, and then maybe it comes up later over time. And because what we don't want is, I've had that experience in several times where someone can't get out the door fast enough because they weren't really ready to think about that. And I guess the other thing I wanted to say is I'm very impressed by my pediatric colleagues and sort of like the work that they do. So like oftentimes I get referrals and talk with one of our pediatric colleagues, and they might feel, you might pick up on a sense of sort of like feeling like, oh, I wish I could have done more. And what I oftentimes find myself saying is like, we wouldn't have done anything differently. Like in terms of, Dr. Rock made the point about like sometimes you really have to sort of like start with treating ADHD or treating anxiety, and then you realize like after you've gone down that path that, okay, like the question of autism spectrum disorder becomes a lot clearer. And so I guess I just want to say that out loud because one, we tend to have the luxury of meeting with our patients more frequently than pediatricians do. And so like, I think I generally see, and we have the luxury of sort of lots of other trials and treatments coming to us beforehand. So I wanted to mention that. I did want to say something about sort of like the generational shift in sort of like how we think about autism spectrum disorder. Like we all know that sort of like that the rates of diagnosis are much higher today than they used to be. And I always think of like those funny memes you might see about someone who like, oh, the the 50-year-old who has $200,000 worth of model trains in the basement and lives down the street. No, he's just neurotypical, right? Like, I think it's, I mean, my belief is clearly that sort of like we've broadened the autism spectrum, and so we're capturing sort of people who didn't have the benefit of a diagnosis. And I want to say a little bit about stigma, because I think stigma is so important. And it's an area where I actually feel quite hopeful about the direction that the world has moved in sort of a longer term, right? That I think that, like, if you look back over previous generations, that sort of like there was, I do think stigma has gotten better. And I do actually, I love it when a adolescent patient comes into me and they're like, I think I have autism, I think I have borderline personality disorder, and I'm like, that's awesome, right? I really, because I think, like, if you're curious and we can explore, right? So I do think that that's actually, I think that's a healthy development in society, that people, I then often find myself, and I know other psychiatrists do, talking with patients about sort of the danger of identifying with being in a sick role, or the danger of sort of identifying, taking ownership for, say, like all the problems within a family system, right? Maybe you want a diagnosis because it's easier to be the problem than to accept something that's sort of not about you. But that leads to me to think a little bit about sort of like some of the people we work with will not sort of think about autism spectrum disorder the same way that we do, or that everyone, and I think that's really okay, right? But I think it's really important to understand, like, getting to know your colleagues and understanding how they think about different constructs, right? So, because we don't always have to think about everything the exact same way, and I would say I've made maybe some progress in this way as I've gotten a little bit more experience, and I would say, bringing back to sort of like intellectual vanity, I would say that, earlier on, maybe I still do this, I would come across a case and I would think, oh, I know what it is, and I think the truth is you don't always have to get the diagnosis right. And you can collaborate with people who think about something differently. And one way I think about this, just to draw a parallel, I was at a training for good psychiatric management for borderline personality disorder, and they had this great sort of quiz section afterwards, and one of the questions was, you're working with a skilled therapist who has a really great relationship with the patient. You're very confident the patient has borderline personality disorder. The therapist doesn't believe the patient has borderline personality disorder. ABC, one of the answers is like, patient needs a new therapist. One of the correct answer is like, it's fine, right? Like, it's fine that the therapist who has a good relationship and is helping the patient doesn't share your same thought for the construct. So, yeah, that was my. So this was what the sort of my assigned topics for today. Sort of expectations and targets for medication, choosing specific medications. The one that I really think matters, like to me, and has mattered for the work, is addressing the question of ASD when treatments don't help other diagnoses, right? So I think this is sort of where my role really has predominantly been, is that someone's coming into my office and the autism spectrum disorder is a very valuable construct. It's not the whole picture, right? But it's sort of really sort of quite relevant. And I would say that really, like, you have to start there and then back up to the other, like choosing specific medications and expectations and targets for medications, or even setting up a medication trial to be successful. So oftentimes that's where I see, the most of the work I do with families in this population is very little about medication, right? I actually don't feel like that's a very small part of, obviously have to know about medications and be informed, but I think the bigger work is really around sort of like, how do you contextualize the role of the medication? How do you help families, schools, individuals understand sort of autism spectrum disorder? And how it pertains to sort of some of the challenges they're having. So, like, sort of a lot of sort of individuals need maybe some validation that like they don't have to work against their nature. And sometimes that's, and that's particularly relevant, I think, with individuals, but sort of certainly with like parents and schools, right? That sort of, so that's where I feel like most of the work that I do is really sort of exploring that question and sort of working with individuals, families, and schools about sort of like where someone is getting stuck. And then one of the things that I wrote, so somewhat related, is thinking about, why is it that we see such a high prevalence of autism spectrum disorder in with other co-occurring conditions, and I just wonder about sort of like, always wonder about sort of early intervention, right? And sort of like that this is a population where early intervention is so powerful, right? And I can think of sort of clinical examples of like, boy, I wish I'd sort of been able to sort of intervene earlier before it was a problem, and be able to sort of provide someone with the missing skills they need to sort of avoid some mishaps. And I think, and I do think, wondering about sort of like, if we were really on a societal level, were to be able to do a much better job at sort of supporting neurodivergence and providing interventions for areas of challenge, like could we in fact prevent the development of more severe chronic mental illness? And I believe so. I believe that that's just my personal belief. I can't back it up with any data, but I do truly believe that if we sort of, by intervening early with autism spectrum disorder and ADHD, and sort of identifying autism spectrum disorder early, instead of having like more of like a waiting to fail model, like, you're doing okay, and maybe you are doing okay for a period of time, but then you're coming back, and maybe we could have done something early to prevent that from happening in the first place. So I think it's a great idea to be, and that maybe we really could be doing a lot more to identify these deficits. And there's several child psychiatrists in the room, so we can also use their benefit in terms of how they think about some of these questions, in particular sort of like questions about sort of like medications for treating co-occurring disorders when you have autism spectrum disorder. So I guess I was going to say that I think sort of like oftentimes our pediatric colleagues like do a I often feel like I'm like, for straightforward ADHD, like you probably want to go to see your pediatrician because they're probably better than I am, right? They have much more experience than I do at treating sort of uncomplicated ADHD, and the same is true for anxiety. So I think and so I think there are like some nuances in terms of like treating co-occurring conditions in autism spectrum disorder, but they're really, the way that I think about it is they're not really that big, right? I mean, I think we know like sort of like there's evidence for Strattera in treating inattentive symptoms in people who have autism spectrum disorder and ADHD. Like that's sort of like one example where I think of like sort of a niche role. And I think that like there's some recommendations where like the Lurie Center has specific recommendations for depression and anxiety in autism spectrum disorder, but I don't think that that's necessarily our same patient population. So I generally don't do anything differently in terms of or anything. If I'm working with a patient who has autism spectrum disorder and ADHD or autism spectrum disorder depression or autism spectrum disorder and anxiety, like I think first providing some context for like and thinking about things like demoralization, right? Unrealistic expectations, non-pharmacological interventions, but then I'm not really thinking much differently about the pharmacologic choices I make, other than if or at least I don't think it's dependent on them having autism spectrum disorder. So I think that's kind of like a spoiler for me. I don't know if Dr. Moss, or if you think about it any differently, but.
And I was kind of thinking of a case that, if it's okay, I might kind of bring up, because I really, really struggled with this case for a variety of reasons. So I had an 8-year-old girl who came in and was referred to me kind of for like anxiety and then having some pretty significant like emotional dysregulation and some aggression towards siblings at home, but doing phenomenal at school. So she came to me and I think already had been referred to for a neuropsych eval in the community. The neuropsych eval in the community was someone who wasn't certified to do an ADA, so they did social reciprocity, social responsiveness, which was, you know, their kind of formulation of her was that they felt like she likely had autism, but couldn't formally diagnose her with this, which put her in a real pickle at school, I think, being able to access some of the resources. But school didn't really see her as being severely impaired, but she was doing so well there. And I really felt like she had autism. And just some background for me professionally, I used to be in ed tech, and I was also a BHP, so I have experience working in a more behavioral model with kids on the spectrum. And I'm also the parent of a child with autism. And so I bring that up because there was a lot of, like each appointment was really, you know, parents were really expressing kind of the severity of symptoms. And I had to really kind of check myself because some days I'd listen to her stories and think, that's like a typical Tuesday night in a mosque household, right? And then I would think too about like the severity of kiddos that I supported in a behavioral role where, you know, nonverbal, non-toilet trained kiddos with severe aggression. And so, you know, but each time the appointments were like asking for higher doses of, you know, risperidone. And I started risperidone. I usually will limit that medication because of the metabolic side effects. And I don't know if this is right or wrong, but I really prefer to see those kinds of symptoms kind of across multiple settings, like, and there was like nothing at school. But there was this aggression towards younger siblings, and mom's like really just kind of like begging for something. And so the risperidone was helpful, but then she started having lipid abnormalities. And so I was starting to say, like, we got to do something different. While mom was saying, no, we have to go like higher on the risperidone. And I had referred her for therapy, and she had started to make some progress on some of the cognitive rigidity, but the family had a hard time accommodating therapy appointments during the day, right? Both parents work, there's 4 kids in the house, like, and so I bring this case up because I think from like a psychopharm standpoint, it started to get a little complicated, but then I also started to feel like I was in conflict with the mom at every single visit. And then it got to the point where she had said, like, I feel like I'm not being heard. And for me as a provider, like that, I was like, whoa. At which point I referred to you guys down at COE. And it felt, I think for me as a provider, I felt like a failure in this case. And I just also, like, I never shared with the mom that I was also a parent of a kiddo with autism, but it also felt like I was like, I hear you, like I'm in this with you, like I'm in this with you, right? But I also don't want your kid to have metabolic syndrome. And so I'm just kind of curious about, like, I really, really worry about the use of atypicals in kids. And we saw such a spike in atypicals being prescribed to preschool kids when there was that whole unfortunate pediatric bipolar train that folks were on, and that was happening in primary care, right? And so, I don't know, I'm just wondering, like, kind of thinking about the context of this case in particular, kind of how we navigate using atypicals in this population.
Yeah, I think so. Like the one slide I had about sort of like irritability, right, is sort of like that, and I use sort of the sort of proposed guidelines from the Lurie Center that may reference sort of irritability and aggression and sort of, you know, and first sort of maybe I'll just click forward a bit to. So first, right, yeah, so irritability, sort of like obviously, right, we're thinking about sort of like other things first, right? So side effects from other medications, sleep disturbances, GI distress, sensory sensitivities, anxiety, depression, ADHD, right? Unrecognized pain and discomfort. And then their recommendation for irritability was like pretty straightforward. So, right, if you've sort of addressed anxiety, depression, ADHD, medical concerns, sleep concerns to the best that you can, like if there's no immediate safety concerns, guanfacine. And then for immediate safety concerns, risperidone or Abilify. And yeah, and I know, yeah, so I think I'm like right there with you in terms of, right, if there's a safety concern, right, and it's sort of like that's usually sort of like the calculation I'm using for sort of like thinking about like an atypical going more quickly to an atypical when there's really safety concerns, and because you have to sort of like quiet things down, and it makes you think a little bit about sort of like just sort of like how the paradigm of treatment changed during the pandemic to a certain extent, right? Sort of like the way that we engaged in treatment really changed, that like oftentimes like just the access to services like decreased so much that you just didn't have we couldn't sort of follow, I think, what we would have previously followed in terms of like our hierarchy of treatment, because a lot of the non-pharmacological treatments weren't available. Yeah. I don't know if anyone else has any other thoughts about Dr. Moss's case.
The other thing that comes to mind for me, which is obviously from a behavioral lens, not from a pharmacological lens, is just appreciating the family dynamics that you're describing. You know, a parent who's at home with 4 children and may have more than one who has some neurodevelopmental need. That's really hard, and it's really hard to ask them to do more. And I know from sort of behavioral interventions also aren't easy to implement, and they require consistency and to implement. But what was occurring to me was that this young woman is doing well at school. And so is there an opportunity, and I'm likely you connected with the school, but like what are the key supports in the school setting that are supporting her success? Are there 1, 2, or 3 things that they're doing consistently in school that we could think about implementing at home? Not that that's going to be curing all, but with great appreciation for how difficult it is to implement behavioral interventions at home, is there 1 or 2 things that we could borrow from the school in terms of supports?
I want to give Dr. Small enough time, and I just wanted to maybe mention 2 quick things. One was, in terms of thinking about like we talk about this a lot with the fellows in terms of like the importance of sort of like really knowing the psychologists that are doing testing in your area, and sort of not being sort of you really need to know sort of like who's good at what, and right, and also sort of like being able to sort of interpret all the measures that are used, because like you might have someone who's really well thought of, has a great reputation for evaluating for high functioning autism spectrum disorder, but maybe there's a time crunch, maybe there's something that so I just think that like we talked with the fellows about sort of like really sort of becoming critical about sort of evaluating the psychological evaluations. The last thing I wanted to mention before I turn things over was this caused me to sort of think about sort of all the cases that I've sort of seen, like in just sort of like the range of sort of presenting symptoms that were really sort of like the question of autism spectrum disorder was at least key to sort of the presenting concern. So like the really complicated young kids with impulsive aggression, concern for prodromal psychotic illness and bipolar disorder. Like sometimes those are really gratifying cases when there's like, no, this is not actually a symptom of psychosis, and refractory anxiety, where they're getting appropriate treatment, but sort of the construct of autism spectrum disorder, the challenges are not being recognized. Depression, demoralization, I feel like is a really big one, where sort of like, I think about sort of like someone who's a rigid thinker who has a rigid teacher, and sort of like how that can sometimes lead to like profound demoralization. And then ARFID, like sort of like a lot of these kids who, whenever I hear ARFID, I'm always like thinking like, is there is autism spectrum sort of will pop up in my mind as a question. So I just wanted to mention those. It's great audience participation. So I will hand things over.
So I'm a psychologist to behavior analyst, and I've been asked to talk about sort of models of behavioral interventions, what some models of behavioral care look like, and was asked to talk about how managing challenging behaviors within a primary pediatric setting. So I think, given the amount of time, it's my understanding that we will have a second talk in several months in September. Great. So I may only, right now get through the models of care, and then happy to talk about the introducing and reinforcing behavioral interventions in pediatric settings next time, and/or field specific questions that would be happy, we'd be happy to address whatever questions folks have and to gear this information towards what will be most helpful. And then this third bullet here, role of parents, this has come up in some of the conversation that we've already had. And as I talk about different models of care, this will continue to come up because it is critical to nearly all behavioral interventions that we have some parent caregiver involvement and support. It's highly unlikely that an individual with autism can participate in treatment, whether it's in an outpatient setting or an in-home setting, and be expected to generalize what they're learning to all of these naturally occurring situations at home and in the community without parental support for the generalization. And that's just something to be thoughtful of when we think about accessing care. So we have, at the COE, we have a lengthy wait list of kids and families who are waiting for services. And we ask all of our providers within our group to really talk with families about that sort of expectation of involvement and to assess to what degree folks are able to participate and support the interventions in home. So I do want to talk a little bit about, of course, about behavior analysis. And I'm going to talk first about what it is for a couple of slides, hopefully highlight what it looks like. And then I do have a slide, maybe 3 or 4 down the road, that is designed to dispel some myths and address some potential controversies. And I'd be happy to field questions and chat about this. I was initially trained in behavior analysis almost 30 years ago, which makes me feel really old, but I've been in this field for a long time, and I've seen the evolution of applied behavior analysis, and what it looks like now is very different from what it looks like 30 years ago, and I'm proud of that. We have evolved, as we should, right? Every field should evolve. But I think that some of the questions, concerns that are asked that should always be asked are reflective of perhaps some old school ways of doing things, and I feel very strongly that contemporary behavior analysis is addressing those questions. So, what is ABA? It is simply the application of the science of human behavior to problems of social importance, problems of social significance. And we think about, oftentimes when we think about ABA, it conjures up the more comprehensive ABA program, that perhaps somebody is receiving 30 hours per week of applied behavior analysis in a home. And there's good evidence to support that. And that is one where there are ongoing assessments, developmental assessments, skill-based assessments, intense intervention that is happening in the home, in the community, other settings. And that's really important. But there are also these more focused ABA approaches, which is sort of what we're doing in our center, which is problem-focused. I have a question, I have a concern, there is a discrete problem, and we're applying behavior analytic interventions to address those problems. Key components in behavior analysis, 2 things I want to think about. One is assessment. I think you mentioned functional behavior assessment. That would be an entire talk in and of itself, but we do complete functional behavior assessments, which is just an umbrella term for a wide variety of assessment measures designed to help us understand why behavior is occurring. What are the variables that are influencing behavior occurring and or not occurring, and what might be reinforcing the behavior, what's keeping it around, and that really drives intervention. I often tell people, I could see 4 different 12-year-old boys who have physical aggression in the same day, and they may have 4 very different treatment plans because the reason why physical aggression is occurring is very different for all 4 of those patients. But our core sort of approaches to addressing behavior are 4 things. One is antecedent or prevention strategies, and this is where parent involvement is really important. There are things like, do we have good sleep hygiene? Do we have good routines? Are we presenting choices to our kids and offering choices of, okay, it's time to brush your teeth. Do you want to do it at 8 or 8:05? Is a choice that an individual can make. Those are prevention strategies. 2 is teaching skills, and I would say this is really critical to the success of behavior analytic interventions. When we think about particularly challenging behaviors, we think about challenging behaviors are happening. Kids don't want to have challenging behaviors. Kids don't want to have physical aggression, have property destruction. They're doing it out of distress and because they don't have other skills to help manage the frustration or navigate complex social interactions. So we really want to be building skills so that kids don't have to use these challenging behaviors. Third area is reinforcement. So applied behavior analysis is going to rely heavily on positive reinforcement. That's very individualized for each child and family. We are reinforcing the skills that we're trying to teach. We are reinforcing the absence of challenging behavior. Very intentionally. And then for our responsive procedures, or sometimes what people talk about as consequences. And I often tell families, if these are our 4 areas: prevention, teaching, reinforcement, and the responsive procedures. Oftentimes people come in and say, well, my child, is tossing over furniture. What do I do when he does that? They're asking about the responsive procedures, right? The consequences. What do I do when? If we're headed in the direction of long-term behavior change, what we really need to do is focus on 1, 2, and 3, the prevention, the teaching, and the reinforcement. So I often say if I have 10 eggs, 9 of my eggs are going in buckets 1, 2, and 3. I'm going to put an egg in the responsive procedures, but that's not what's going to drive long-term change, because really what we need to do is be building skills in our kids to help them manage the frustration, manage the stressors that they're encountering. And again, the role of parents and caregivers is critical to the success of our interventions in nearly all circumstances. So this is just a slide highlighting that applied behavior analysis is really trying to do 2 things. We are trying to teach skills or sort of remediate these deficits. There's often a focus on functional communication, helping children just to be able to ask for what they want. I want something to eat, I want a toy, or I don't want something. Learning to appropriately protest something. We all have the repertoire to say no thank you, and a lot of our kids don't have that, or it's not honored when they use it, in which case children may begin to use some challenging behavior. Social communication skills and social skills, increased independence with self-care, and that's across the spectrum. We really think about helping individuals to become as independent as they can be. And that might be, we really want, as our individuals with autism are aging, we really want them to be able to independently care for their bodies. That's really important. And it could really, in other individuals, it could really be self-advocacy. Somebody who's going off to college is going to need to be able to advocate for their own needs. And again, building coping skills, and then we're often reducing challenging behavior, or trying to, whether that's aggression, self-injury, elopement, property destruction, all of these sorts of challenging behaviors. And these 2 things go hand in hand. As we're building skills, we should be seeing challenging behavior go down. So I just wanted to provide in our current setting, run through one or two case examples, and then I will, just being mindful of time, run through one or two case examples, and then I do want to get to the slide on sort of myths around applied behavior analysis or controversies and talk about that. So this is an example of sort of what focused ABA might look like. So thinking about an individual 6-year-old female who has more profound autism. So really nonverbal, very limited functional communication skills, very limited independent leisure skills. Other than looking at the tablet, doesn't really engage in a lot of other skills, and presents with some head-directed self-injury, so hitting herself in her cheeks and her chin. And this has been really stressful in the family. In the family, there is another sibling who has significant medical needs. Both parents are working, trying to support their family. They are accessing psychiatric care, and this young girl is on methylphenidate. And there's a referral for outpatient ABA. Completed a functional assessment and identified that the self-injury was being maintained by access to things that she wanted, most notably food. So what was happening, and this may have been shaped up over time, what was happening is this young child would punch themselves, and family, very intentionally wanting to help calm and soothe her, would give her food. Very limited repertoire of food that she wanted, but reliably you would see punch and then a delivery of a food, of snacks. And so really what her treatment has involved is teaching functional communication skills, teaching her another way to ask for the food. She comes in with a parent, and the parent is actually the one who's delivering the treatment even in my sessions. So I'm modeling it at the very beginning. We have step one, I'm modeling it, and I am immediately handing it over to the parent, and then I'm coaching the parent in our office to be implementing this, and then talking with the parent about what is feasible at home, and setting a plan. The plan we set with this individual was, could they practice once per day at home? Pick a time at home where you can set aside 5 minutes and practice this. I can't expect somebody to go home and do this all day when they might be the only parent at home with 2 children who have, different special needs. But 5 minutes, is that possible? And this is a very committed family who is doing this and is now doing 5 minutes 3 or 4 times per day, coming to every appointment, willing to, to learn this intervention and apply it at home. But the role of the parent and caregiver involvement is critical to the success for this patient. And I will say the last time that I saw them, the bruising and swelling had gone down, which was really exciting. Oh, I forgot to mention, there had been a DHHS report on the family for neglect because she had bruising and swelling, which is like another stressor, right? Adding guilt to the family who is doing their very best to support a child with significant challenging behavior. But this is an example of sort of a focused ABA approach. It's not 30 hours per week of behavior analysis in a home, but it is, here is the problem and here's how we're utilizing the principles of behavior analysis to teach and address this one specific skill. And I am very mindful of time. What I do want to do, do I have time? Do I have like 5 minutes? Yeah. Okay. Is just talk about this one slide. And I'd be happy to chat, but there are a number of myths about applied behavior analysis, and I want to address a few of them. First is that ABA is only for children with autism. Great news is that there are insurances that pay for ABA for children with autism. Even better news would be if insurances would pay for ABA for people who don't have autism, because ABA is not an autism treatment. It's the application of the science of human behavior to problems of social significance. We do have a lot of empirical evidence for its application with children with autism, but it is actually helpful with a wide variety of behaviors. Children who have ADHD, neurotypical children. I may be doing this in my home. So it is, it is addressing gambling. I have a colleague who works in organizational behavior management. It addresses a wide variety of behaviors. Myth number 2 is that ABA doesn't respect an individual's preferences or unique needs, strengths, and values. Applied behavior analysis, by definition, is very individualized, and in our work, we are addressing problems of social significance, problems that are important to the individuals with autism and their families. So the goals that we are establishing are being established by sitting down with our patients and their families. What is problematic? What's getting in the way of this individual being able to participate meaningfully in their school, in their home, in their community? And those are the problems that we're addressing. Myth number 3 is applied behavior analysis turns children into robots. We do often use a systematic teaching approach to introduce new skills, but good behavior analysis is going to help with flexibility. Good behavior analysis is going to address generalization. We don't want individuals using scripts. We may start with scripts as a sort of stopgap, but we absolutely want to teach flexibility and teach children to respond in a very social environment that's difficult to predict. Number 4, that we're heavily focused on punishment and rigid discipline. And I do think this comes from what was happening many years ago in behavior analysis. But as I mentioned a couple of slides ago, applied behavior analysis is very focused on utilizing positive reinforcement to teach skills, and use of punishment procedures and sort of rigid discipline is not the hallmark of contemporary behavior analysis. And then myth number 5 is ABA is outdated and harmful. And I should note, the most recent code of ethics for behavior analysis is very heavily focused on compassionate care and engaging our patients and our families in goal setting and the evaluation of both our interventions and of our outcomes. So I think those are really important. We are addressing problems of social significance. So some of those core characteristics, take stereotypy, for example. Stereotypy 15 years ago was a primary target of treatment. And now, if stereotypy is not getting in the way of learning, engaging with peers, participating in whatever it is that somebody wants to participate in, then we're not targeting that as a goal of treatment. And that's a good example, I think. Along with eye contact, right. Yeah. Yeah. Thank you.